Well, good morning, everyone, and welcome to Grand Rounds. And I am Dr. Betsy Trowbridge. I am the Executive Vice Chair for the Department of Medicine. And I want to welcome everyone to the first week of spring. And right on time in my garden, the Helleborus or Lenten roses are just getting ready to bloom. And so that always makes me feel like hope is in the future. And today we have a fantastic Grand Rounds entitled Upfront Treatment of Advanced Ovarian Cancer, OI, now the plot thickens. Great title. And this is with Dr. Elisavet Paplomata, and she is an assistant professor in the Division of Hematology, Oncology, Medical Oncology, and Palliative Care. And for her introduction, I would like to have Dr. Carrie Wazinski, who is our interim division chief for Hem-Onc and Palliative Care, introduce her. Dr. Wazinski, please go ahead.
Great. Good morning, everybody. It really gives me great pleasure to introduce Dr. Paplomata, who goes by Elsa for her first name. So Dr. Paplomata graduated from the University of Istanbul in Turkey with her medical degree, and then completed her internal medicine training program at Presbyterian Hospital in Dallas, Texas, followed by a hematology oncology fellowship program at Emory University. She then joined the faculty at Emory in the Hematology Oncology program until February of last year, when we were lucky enough to recruit her to come to the UW. So she came, right as the pandemic was hitting, and she's really hit her stride here despite those challenges. So she is a medical oncologist who partners both with our gynecology oncology clinic colleagues on the management of systemic therapy for patients with gynecologic malignancies. And she's also been a great addition to our breast cancer clinical care team. Dr. Paplomata is leading multiple phase 1 to phase 3 clinical trials here at the UW, as she had done at Emory. And these are all evaluating new therapies for breast and gynecologic cancers. Recently, Dr. Paplomata was selected as the co-chair of the Gynecology Oncology Working Group of the Big Ten Cancer Research Consortium. And I'm sure that she's going to continue to lead many great studies here at the UW. Just as a side note, Dr. Paplomata is a huge athlete. She has done several Ironmans, and Madison has been, I think, a great place for her to continue to do those things that she enjoys. So I'm excited to invite her today and hear her talk about this update on ovarian cancer.
Yes, good morning. Thank you, Carrie. Thank you for the kind introduction. I'm very excited to be giving this talk to this audience. And I'm sorry, because of COVID, I haven't met many of you in person. These are my disclosures. So while preparing this talk, I discovered that "now the plot thickens" is a phrase coming from the play Rehearsal, played in 1671 and written by George Villiers, where they say, "Aye, now the plot thickens very much upon us." It is not a soup. I don't know if you've seen the Wes Anderson movie, The Grand Budapest Hotel. It's a hilarious movie if you haven't seen it, but it just means, it's a metaphor. It means that something is becoming interesting and exciting. And I thought that was exactly the description of the management of advanced ovarian cancer. I will talk briefly about the background on ovarian cancer. I will talk about the role of neoadjuvant chemotherapy for advanced ovarian cancer, the role of intraperitoneal chemotherapy and HIPEC, anti-angiogenic therapy, genetic and genomic testing in patients with ovarian cancer, and the role of PARP inhibition. Let's start with a case history. If we have a 56-year-old female who presented with several months of worsening abdominal distension and pelvic pressure, on imaging, she was found to have a large pelvic mass measuring 10 centimeters, large volume ascites or mental caking. CT chest is normal and has an elevated CA125. She has no family history of cancer, so we'll see how that affects her genetic counseling eligibility. She's a teacher with an active and healthy lifestyle. What is the best next step for these patients? This is the patient we are going to be talking about. So some background: ovarian cancer is the second most common gynecologic cancer in the United States after uterine cancer. However, it is the #1 cause of death among gynecologic cancers in the United States and #2 worldwide. Most ovarian cancers, and that includes fallopian tube and primary peritoneal cancers, are epithelial cancers. Less common cancers include germ cell and sex cord tumors. This talk is going to exclusively focus on epithelial ovarian cancer. So I will not be talking about rare variants and subtypes. As we see here, estimating new cases of cancers among women in the United States, breast cancer is #1 in incidence, and ovarian cancer, we have about 21,000 cases per year. However, when we look at estimated deaths per year in women here on the right, ovary is #5, with about 14,000 women estimated to die every year. About 1.2% of women will be diagnosed with ovarian cancer at some point during their lifetime, with a median age of 63 years, and a 5-year relative survival of almost 50%. And when I give this talk for breast cancer, like Dr. Wyszynski mentioned, I practice both in breast and GYN cancers. That 5-year relative survival is 90%. So this is definitely a different disease, and definitely we can do better. As we see here on the right, most cases are diagnosed at an advanced stage. And this is why we do not have an effective screening strategy like mammograms for breast cancer. And many of the symptoms are non-specific, like GI symptoms, distension, pelvic pressure. Many times these symptoms are attributed to GI causes and go unnoticed for a while. So patients end up diagnosed with advanced disease. And as we see here on the right lower corner, 5-year relative survival does correlate with the stage of diagnosis. So the more advanced the disease, the worse the outcomes and the 5-year survival. This is a slide I made with the history of ovarian cancer treatment. So before the 1950s, we had surgery and radiation as the only treatment strategies. Actually, the first mention of debulking surgery for ovarian cancer was in the 1930s by Dr. Meek at the Mass General Hospital. In the 1950s, chemotherapy was introduced. In the 1960s, it was found the combination of surgery and chemotherapy was the best option for these patients. In the 1970s, we had the discovery of cisplatin, who at the time was probably a miracle drug. It had great clinical responses, including complete responses. In the 1970s, we also had the development of the concept of optimal debulking. Optimal debulking means that at the end of surgery, the surgeon reports that there is less than 1 centimeter residual disease in the abdomen. So it was shown even from the 1970s that optimal debulking is associated with outcomes. Actually, Dr. Griffith in 1975 reported that patient who had the less cancer was left after surgery, the better the survival of the patient. In the 1980s and 90s, we had the addition of taxanes to the platinum backbone. It was found that adding a taxane, docetaxel or paclitaxel, actually improved outcomes in these patients. And eventually in the 21st century, the primary backbone for the chemotherapy of these patients is carboplatin, because carboplatin has same efficacy, but is better tolerated than cisplatin with paclitaxel. Docetaxel is another taxane used. However, again, same efficacy. Docetaxel is a bit more myelosuppressive, and paclitaxel is considered better tolerated, other than neuropathy. It's not until the 1990s that we have discovered the breast cancer genes 1 and 2, and not until 2014, where we have the first drugs which are not chemotherapy, olaparib and bevacizumab, approved. And I actually did graduate fellowship in 2014, so this is exactly where after that we have had the most developments. And I will talk about these drugs in my talk. So this talk is mostly going to focus on patients with advanced stages of ovarian cancer. Advanced stage 3 and 4 means that the cancer is beyond the pelvis, in the upper abdomen, with or without positive nodes. And stage 4 cancer is when the cancer is outside the abdomen, in the lungs, the bones, inguinal lymph node, malignant pleural effusion, or intraparenchymal liver and spleen lesions. So most of the trials I will mention include stage 3 and 4 patients. So I will start with neoadjuvant chemotherapy. So why do we give neoadjuvant chemotherapy? Neoadjuvant chemotherapy is being used more and more in multiple cancers, including breast, GYN, and other cancers. With neoadjuvant chemotherapy, we can potentially convert an inoperable cancer to operable. For example, in the case of breast, we can convert a mastectomy to a lumpectomy. In the case of ovarian cancer, we can increase the chances of optimal cytoreduction. So, take more of the cancer out of the abdomen. It can give prognostic information. So essentially, chemosensitive cancers have overall a better prognosis. Cancers that actually progress on first-line chemotherapy are platinum refractory, resistant, and chemo-resistant, and they are considered to have worse outcomes. And sometimes, the response to neoadjuvant chemotherapy can adjust adjuvant management decisions. So neoadjuvant chemotherapy is important. However, it was really not the standard of care for many years for ovarian cancer. This is one landmark study. It was published in 2010. It included stage 3 and 4 ovarian cancers, and patients were randomized to what was the standard of care, primary surgery, followed by 6 cycles of chemotherapy, and that was the carboplatin paclitaxel, though they allowed cisplatin, versus the experimental arm, give 3 cycles of chemotherapy first, surgery, then 3 more cycles of chemotherapy, like a sandwich approach. And that study, this was an inferiority study. So what we wanted to do, show that chemotherapy before surgery was not inferior to surgery up front. And it did show that median survival was similar between the primary surgery and the neoadjuvant chemotherapy arm, 29 months with surgery and 30 months with neoadjuvant chemotherapy. And we look here on the top right corner, that really the lines overlap. And again, that was a non-inferiority study, so it did meet the primary endpoint that neoadjuvant chemotherapy was not inferior to primary surgery. We're looking at the top lower corner in the Kaplan-Meier curve. We do see that patients did better regardless of the arm if they had optimal debulking, no residual disease, or residual less than 1 centimeter, which again confirms that, the outcome of surgery is very important for long-term outcomes. Another similar study was the CHORUS study, which was published 5 years later. That was again a non-inferiority study. It did include stage 3A and B cancers. Again, similar design, like surgery, 6 cycles of chemotherapy versus 3 cycles of chemotherapy, surgery, and 3 cycles of chemotherapy. Again, we see here that the outcomes were very similar between the 2 arms, overall survival and progression-free survival. And that was, again, a non-inferiority study. So again, neoadjuvant chemotherapy was not inferior to primary surgery. A pooled analysis of these 2 studies that led to having 1,200 patients to analyze, again confirmed that when it comes to overall survival and progression-free survival, the 2 arms did pretty much the same here when we look at the intention to treat population. When we look at stage 4 patients, so patients, I remind you, who had disease outside the abdomen, like pleural effusions, lung metastasis, bone, intraparenchymal liver, neoadjuvant chemotherapy did slightly better with 24.3 months versus 21.2 months with a hazard ratio of 0.76. So these might be patients that would benefit more from neoadjuvant chemotherapy. When we look at residual disease in surgery, as expected with primary chemotherapy, the rate of optimal debulking and no residual disease was better in the chemotherapy arm. And when we look at the adverse events, and that was the same, consistent with the EORTC study, the grade 3 and 4 adverse events were higher in the primary surgery arm, and that was for the first month after surgery, including infections and death within 28 days after surgery. And this is a meta-analysis of neoadjuvant chemotherapy studies, including other studies and EORTC and CHORUS. And it's a very busy slide, but I want to make 3 points. Again, this confirms that patients who have neoadjuvant chemotherapy have less operation time, so less time in the operating table. Patients who have neoadjuvant chemotherapy have higher rates of optimal cytoreduction or complete cytoreduction. And patients who have neoadjuvant chemotherapy had less adverse events, grade 3 or more, in the first 28 days after surgery. So based on these studies, so we see that neoadjuvant chemotherapy plays a role in advanced disease where complete resection is not possible up front. However, neoadjuvant chemotherapy should not substitute efforts for optimal surgical care. And all patients need to have a gynecologic oncology consultation. You might think this goes without saying, but I'm a medical oncologist. I should not be the one making that decision. A gynecologic oncology consultation is required, and the gynecologic oncologist is going to decide whether a patient is a candidate for upfront surgery and potential complete cytoreduction with upfront surgery, or requires neoadjuvant chemotherapy. And another thing I didn't mention before, but again, we should never forget all patients who receive neoadjuvant chemotherapy do require a biopsy. Now we'll go to intraperitoneal chemotherapy, and I will mention HIPEC chemotherapy first, which stands for hyperthermic intraperitoneal chemotherapy technique, introducing installation of heated chemotherapy into the abdominal cavity at the time of surgery. There are several trials now that demonstrate that HIPEC is feasible and tolerable, and there are several studies in the upfront setting and the current setting. The HIPEC procedure is designed to attempt to kill any remaining cancer cells after surgery. The procedure improves drug absorption and effect with minimal exposure to the rest of the body. That's the rationale of the procedure. We see here in this study that was published in the New England Journal of Medicine in 2018, when we compare no HIPEC versus HIPEC, the median recurrence-free survival was 10.7 months in the surgery-only group and 14.2 months in the surgery plus HIPEC group. The median overall survival was also slightly better in the HIPEC group, 33.9 in the surgery group, and 45.7 months in the surgery plus HIPEC group. What are the side effects of HIPEC, though? Why do we do HIPEC in all patients now based on this data? Side effects was infection in this study, 18% versus 11% in the no HIPEC group. Pain, ileus, nausea can be seen more in the HIPEC group. Despite the fact that we have this study and a couple of other randomized studies, HIPEC is not a standard of care. And I can talk about that more in the conclusions. Now, I want to talk about intraperitoneal chemotherapy, which is different from the HIPEC I mentioned before. HIPEC is given at the time of surgery, at the time of closure. Intraperitoneal chemotherapy is given like IV chemotherapy. The patient comes to clinic, and at the time of surgery, if the surgeon decides that the debulking was optimal, so less than 1 centimeter residual disease, a port is being placed in the abdomen, and then the patient receives a combination of IV and IP chemotherapy. So intraperitoneal chemotherapy by itself is different than HIPEC. So this is a landmark study in intraperitoneal chemotherapy, IP chemotherapy, by Dr. Armstrong from Johns Hopkins, that was published in the New England Journal of Medicine. That included stage 3 patients with ovarian cancer who had optimal debulking, so less than 1 centimeter residual after surgery. The patients were randomized to receive a combination of intraperitoneal cisplatin paclitaxel and IV paclitaxel, or IV only cisplatin paclitaxel. Progression-free survival, overall survival were the primary endpoints. And we see here that intraperitoneal chemotherapy did improve both progression-free survival and overall survival in patients who received intraperitoneal chemotherapy with a hazard ratio of 0.8, 0.75 respectively, and that was statistically significant. However, what about toxicity? Not even half of the patients who were in the IP arm completed all 6 cycles of assigned IP chemotherapy arm. By the way, if a patient cannot tolerate IP chemotherapy, then they can complete 6 cycles with IV chemotherapy, but still, many patients did not complete the IP chemotherapy. The main reason of discontinuation was catheter-related complications. However, we see here on the right, leukopenia, thrombocytopenia, gastrointestinal events, fever, infection, metabolic events, pain were all higher in the IP arm. So this is generally not a very well tolerated chemotherapy. It hasn't been, despite this data, it hasn't really become the standard of care for all patients who had optimal debulking, and centers like big centers like UW, academic centers, Sloan Kettering, are probably better fitted to administer this chemotherapy because of the toxicity. Well, another study that kind of put an end in the use of IP chemotherapy in many centers was this GOG252 study. This study was just published in 2019, but it had 3 arms with IV chemotherapy and 2 arms with intraperitoneal carboplatin and intraperitoneal cisplatin. And essentially, the difference with this study included bevacizumab, which is a monoclonal antibody. I will mention it again later and the mechanism of action. But essentially, all 3 arms received bevacizumab, and there were 2 arms with intraperitoneal chemotherapy. And essentially, the progression-free survival and overall survival was not different between the 3 arms. So in conclusion, intraperitoneal chemotherapy has been shown to improve progression-free survival and overall survival in patients who have optimal debulking. However, it is associated with more toxicity. HIPEC, despite some data, these are not sufficient randomized controlled data to make it a standard of care. So it's reasonable to offer HIPEC in specific patients who qualify, and those who have no residual disease after surgery can qualify, but it is not currently the standard of care. What we have to be careful for with HIPEC is 1, the side effect profile, 2, many oncologists, I think, are afraid that if a patient has difficulty recovering from HIPEC, that will lead to a delay in the administration of systemic chemotherapy after surgery. And the third point is that we have to watch for our adjuvant trials. Some of our adjuvant trials exclude patients who receive HIPEC, so we definitely have to watch out. If a patient is interested in an adjuvant trial, HIPEC might not be a good option for that patient. And a large randomized trial for intraperitoneal chemotherapy, including carboplatin, cisplatin, failed to improve outcomes when compared to IV chemotherapy, and toxicity was higher in the IP arms. Now we'll talk about bevacizumab, which I didn't mention it earlier. Essentially, ovarian cancer cells frequently express vascular endothelial growth factor, as we see here, VEGF, and that leads to cell proliferation and survival. So decreased VEGF expression is associated with reductions in tumor vascularization and angiogenesis. Bevacizumab is a monoclonal antibody that binds to all isoforms of the VEGF receptor ligand VEGF alpha, as we see here. Bevacizumab is a drug that has been approved in multiple cancers, including colon, ovarian in multiple settings. So it's a drug that well known to the oncology world. This is a study of bevacizumab, and I know this is a busy slide, but essentially these were patients with stage 3 or 4 ovarian cancer who had surgery, and there were 3 arms: the standard carboplatin paclitaxel backbone of 6 cycles, and the patients either received chemotherapy with placebo followed by placebo maintenance, or bevacizumab with the chemotherapy concurrent followed by placebo, or bevacizumab throughout, so bevacizumab with the chemotherapy and followed by bevacizumab maintenance. The primary endpoint was progression-free survival. And as we see here in the dark line, the bevacizumab throughout arm improved progression-free survival in the primary analysis and the 2011 analysis. However, overall survival was not improved with bevacizumab, which I think is a theme with many studies with bevacizumab. Progression-free survival is improved, but overall survival not for all patients. When we look at updated overall survival results of that study with a follow-up of 102 months, we see here with the final protocol-specified overall survival and disease-specific overall survival for stage 3 patients, really the lines overlap. There's no statistical significant benefit for bevacizumab. However, if we see here only the stage 4 patients, bevacizumab did improve overall survival by about 10 months, 42 versus 32 months compared to control. What about safety? With bevacizumab, the concern is gastrointestinal events, including perforations, hypertension, bleeding, proteinuria, thromboembolisms, arterial or venous. So definitely, these are toxicities we look for in these patients. In a similar note, ICON7 was a study that included also high-risk stage 1 and 2 patients. They had only 2 arms, the chemotherapy arm and bevacizumab throughout arm. Progression-free survival was the primary endpoint. And we do see here on the right in the Kaplan-Meier curve, bevacizumab did improve progression-free survival, both in all patients and high-risk patients, but overall survival did not improve overall survival, 44.6 months versus 45.5 months with bevacizumab. And again, when we see in the upper right corner, the Kaplan-Meier curve, when we see all patients in the 2015 publication and update in the overall survival, bevacizumab did not improve overall survival when we look at all comers. However, when we look at high-risk patients in the top right here, we see that high-risk patients defined as stage 4, inoperable stage 3, or suboptimally debulked did get benefit, again, about 9 months benefit with bevacizumab, consistent with the prior study I showed you. So high-risk patients did benefit again when it came to overall survival. Side effects during extended follow-up was 1 gastrointestinal fistula and 3 grade 2 treatment-related events, including cardiac failure. So in summary, when combined with bevacizumab, with chemotherapy concurrent and followed by maintenance, bevacizumab can improve outcomes in the upfront management of ovarian cancer patients. So it's something we should consider. And patients who benefit the most and might get a survival benefit include high-risk patients and those with stage 4 disease. Toxicities of interest include hypertension, proteinuria, bleeding, thrombosis, gastrointestinal events. And now, a major part of my talk is going to be the emerging indications for PARP inhibitors. PARP stands for poly-ADP ribose polymerase. So forgive me, I'm going to use the term PARP from now on. Hereditary breast and ovarian cancer is an autosomal dominant cancer syndrome and most common cause of hereditary ovarian cancer. The BRCA1 and 2 gene mutations account for most of the cases of hereditary breast and ovarian cancer, and other genes involved may be RAD51 and CHEK2. Women with hereditary ovarian cancer have an estimated lifetime risk of 45% of developing high-grade serous carcinoma of the ovary, 45% when they have BRCA1, and about 23% for BRCA2 mutations. When we look at the pathology by immunohistochemistry, we cannot tell if a patient has hereditary ovarian cancer or not. So we really have to do genetic testing to identify patients who have hereditary ovarian cancer. So the BRCA1 and BRCA2 genes were discovered at Berkeley and London, respectively. They're tumor suppressor genes located in the chromosomes 17 and 13, respectively. They regulate normal cell growth and proliferation, and they play a role in DNA repair, and that's why they're called caretaker genes. Essentially, they repair double-stranded DNA breaks via homologous recombination. Thus, the mutation and the deficient function of BRCA is called homologous recombination deficiency, or HRD. So if you come to the gynonc clinic or you see a gynonc note, you will see the term HRD a lot. However, the mutation in the BRCA1 and 2 genes are not the only cause of HRD. There's other germline or somatic mutations and epigenetic modifications. So HRD is a larger umbrella that includes the BRCA1 and 2 germline mutations. So here you see there's 2 ways of DNA repair: the non-homologous end joining on the left, which is error-prone, so not preferred if there's another option, and homologous recombination repair, which is more stable as a preferred way, and this is where BRCA genes play a role. So when BRCA genes are mutated, we have homologous recombination deficiency. And how do we use this to treat cancer? So this is where synthetic lethality, the synthetic lethality concept comes in, which essentially means that if you have 2 genes that are malfunctioning, either one is malfunctioning separately, the cancer cell will survive. However, if these 2 genes malfunction simultaneously, the cancer cell will die. This is where we use, if there's a DNA damage from chemotherapy or another agent, and there's a single strand break in the DNA that needs to be repaired by PARP. But if we use a PARP inhibitor, this will not be repaired. It will accumulate into a double strand break. And this is where we're going to need the stable and reliant homologous recombination repair, like I showed you in the previous slide. And a cell with a normal functional homologous recombination pathway will repair its DNA and will survive. However, a cell which has HRD will not survive and will lead to cell death. So this is how we use the BRCA mutations and the HRD as a weakness to use PARP inhibitors for the cancer treatment. So who do we test for HRD and when in ovarian cancer patients? The American Society of Clinical Oncology published guidelines about a year ago now about testing, and they recommended all women with epithelial ovarian cancer, regardless of age, regardless of family history, need to have germline genetic testing for BRCA and other pathogenic mutations. So this will identify a proportion of germline mutated patients, and these could be candidates for PARP inhibitor treatment in various settings. If ASCO again recommends, if patients are germline negative, to go on with somatic testing, essentially checking the tumor. And then this will identify patients who are germline negative but have somatic BRCA mutations. So essentially, the tumor has BRCA mutations, but not the patient. And then recently, of course, like I mentioned, the HRD testing really is being used. So if a patient doesn't have a germline mutation, if the tumor doesn't have a mutation in the BRCA, then we need to go ahead and test for HRD. And essentially, again, that will identify patients who will benefit from PARP inhibitors. This is a sample from the Myriad website, which looks at HRD. So the HRD testing includes the BRCA1 and BRCA2, but also is a larger umbrella looking at loss of heterozygosity, telomeric allelic imbalance, and large-scale tail transition. So essentially it gives you a report. The patient is HRD positive or negative. And there's 3 PARP inhibitors approved in ovarian cancer. Olaparib was first approved in 2014 for patients who had BRCA germline mutations and more than 3 or more lines of chemotherapy. Rucaparib also has been approved, and niraparib has been approved. So in the red and orange circles is the first-line treatments, which is what this talk is about. So in 2018, olaparib was approved in first-line setting for patients who had BRCA mutations based on the SOLO-1 study, which I will mention here later. In 2020, we had 2 PARP inhibitor approvals in the first-line setting. One is olaparib again, bevacizumab. So by now, you know what bevacizumab is. I mentioned that already. And niraparib also has been approved for the first-line setting. And I will mention these trials that led to the approval of these agents. So 2020 was really also a big year for the ovarian cancer treatment. So I will mention these studies in the next few minutes. So I will start with the Paola study, which was published pretty recently. Olaparib plus bevacizumab as first-line maintenance in ovarian cancer. So this study included patients who had primary treatment, so surgery, chemotherapy, and many of these patients did receive neoadjuvant chemotherapy. Over the years, neoadjuvant chemotherapy has gained a lot of momentum in ovarian cancer. Patients were randomized 2-to-1 to olaparib with bevacizumab maintenance or placebo and bevacizumab maintenance. So we see here about 1/3 of these patients were BRCA positive, and about half of these patients were HRD positive as well. And when we look here at the Paola study results, olaparib did improve progression-free survival in all patients compared to placebo, with 22 months versus 16.6 months progression-free survival. However, when we look at subset of patients, and I'm sorry this is a busy slide, but essentially in the top left, we see patients with tumor BRCA mutation, and we see how there's such a significant benefit for these patients. The PFS in these patients was 37 months versus 21.7 in the placebo arm. When we look at patients without a BRCA mutation on the top right, not such a significant benefit. And on the bottom, we see patients with HRD tumors. On the left, including those with BRCA mutations. Again, these patients did have significant PFS with a hazard ratio of 0.33. And on the top right, patients with HRD tumors without a BRCA mutations, again, did benefit. And the PFS in these patients was 28 months versus 16 in the placebo arm. In this study, though, if we looked at HR proficient patients, so no HRD, no BRCA mutation. The PFS was 16.6 months versus 16.2 months. So based on this data, the FDA approved olaparib and bevacizumab in patients with HRD positive patients. And that, of course, include BRCA, patients with germline BRCA mutations, and HRD positive tumors. What about toxicity? So with PARP inhibitors, we do have fatigue, GI effects like nausea, abdominal pain, and cytopenias, mainly anemia with olaparib. Veliparib is another PARP inhibitor which hasn't been approved in this setting, so I will go through this trial pretty fast. So here they gave the veliparib with chemotherapy. So chemotherapy placebo followed by placebo, chemotherapy veliparib followed by placebo, or veliparib throughout with chemotherapy and as a maintenance. So again, veliparib did improve patients, mainly the patients with BRCA mutation and HRD positive. And toxicity profile, again, nausea, fatigue, cytopenias were more in the veliparib arm. Niraparib, this is the PRIMA study. So this led to the approval of niraparib in 2020. So these were patients with newly diagnosed breast cancer, ovarian cancer, who had their primary treatment with surgery and chemotherapy, and patients were randomized to niraparib for 3 years versus placebo. Progression-free survival was the primary endpoint. And as we see here in the Kaplan-Meier curves and in the text, progression-free survival in the HRD positive patients was one of the primary endpoints and was 21.9 months with niraparib versus 10.4 months with placebo, and that was statistically significant. In the overall patient population, 13.8 months with niraparib versus 8.2 months in the placebo arm, again statistically significant. In the HR proficient patients, it was 8 versus 5.4 months, so really less benefit, almost 3 months here. However, based on this data, the FDA did approve niraparib for all comers, so it doesn't require HRD or BRCA positivity. However, we do see here that HRD positive patients do get more benefit. As we see here, niraparib did better in most subgroups, including patients who received neoadjuvant chemotherapy, which again we use a lot in advanced ovarian cancer. 13.9 months with niraparib versus 8.2 months with placebo in patients who had neoadjuvant chemotherapy. And adverse events, more patients discontinued the drug or had reductions and dose interruptions. And with niraparib, again, we see anemia, nausea, constipation. Niraparib does cause more thrombocytopenia than the other PARP inhibitors, so it requires more close monitoring with a CBC. And these are expected side effects. And again, this regimen was approved for maintenance in ovarian cancer patients. Finally, with the PARPs, I will present the SOLO-1 data. This is the olaparib study for patients who had a BRCA mutation. These were patients with newly diagnosed advanced ovarian cancer who had a BRCA mutation, like I mentioned, had surgery, chemotherapy with platinum, and had a complete or a partial response to their first-line chemotherapy. Patients were randomized 2-to-1 to olaparib or placebo for 2 years. Even though patients, if at the end of 2 years they had still measurable disease, they were allowed to continue the drug. Progression-free survival was the primary endpoint. In the analysis in 2018, olaparib had not reached the progression-free survival. Median progression-free survival, placebo was 13.8 months. In the updated analysis, this data is from ESMO 2020, but they haven't really changed. Olaparib had a PFS of 56 months versus 13.8 with placebo and a hazard ratio of 0.33. So this is pretty impressive data. What is more impressive is that we see here in the Kaplan-Meier curves, even though most patients, only 13 patients continue beyond 2 years, even after the 2 years, the curves really remain separated. So even though most patients stopped at 2 years, the benefit continued. And this is pretty impressive. At 5 years, 48% of the olaparib arm are progression-free versus 21% in placebo. And the efficacy, the secondary efficacy outcomes also favor olaparib. Again, pretty impressive results here. What about the safety profile? So other than the GI side effects and cytopenias, anemia we see with PARP inhibitors, another concern with these drugs is the risk of secondary cancers, including MDS and acute leukemia. A secondary leukemia, actually can be very difficult to treat and can be life-threatening. So definitely this is a concern with these drugs. And we do know that chemotherapy also can cause secondary malignancy and leukemia. How about when we do both? Well, the SOLO-1 study here actually really has very favorable side effect profile. The incidence of MDS and AML remains under 1.5%. With the updated data, this past weekend, we had the SGO meeting, and updated data of this study was presented and really hasn't changed much. Again, less than 1.5% MDS AML risk. So really, from this aspect, it is a safe drug, and it should be offered for patients who have germline BRCA mutations. And in conclusion, testing for BRCA and HRD is very important, should not be neglected. I hope I showed you how important this is, especially in the SOLO-1 study, because if we don't know which patient has a germline BRCA mutation, we do not know which patients can get the olaparib maintenance. Testing is indicated regardless of age and family history. Very important to know that too. PARP inhibitors, yes, are more effective in BRCA-positive patients and HRD patients, but they do have an indication for all comers. So, reminding niraparib has been approved for all comers. Fatigue, hematologic, and GI toxicities are the most common adverse events. MDS and AML risk is low. However, if it happens, it does carry a poor prognosis. And finally, shared decision-making should be used when it comes to PARP inhibitor maintenance in the frontline setting. Now, finally, I didn't want to put too much data on this, but I want to mention immunotherapy in ovarian cancer. Immunotherapy has a lot of momentum and has been approved in multiple settings, in multiple other malignancies with very good results. Here I'm presenting this study of a backbone of carboplatin paclitaxel chemotherapy and bevacizumab, where patients received either placebo or atezolizumab. These are the baseline characteristics. And essentially, when we look at progression-free survival in the intention to treat population versus PD-L1 population, atezolizumab did not really improve progression-free survival. And we see here overall survival, again, the lines overlap. When we look at patients who had the PD-L1 more than 5%, maybe there is a benefit to immunotherapy in this setting. So these are promising data, but in general, both in the upfront and metastatic setting, immunotherapy has had lukewarm and modest results. Immune adverse events like thyroiditis, pneumonitis, hepatitis can happen in these patients. In this study, also febrile neutropenia and pyrexia was more common in that atezolizumab arm. So in conclusion, some agents, immunotherapy agents have promising activity, but we still need better biomarkers to identify patients who will benefit from immunotherapy in this setting. And no immunotherapy agent is currently approved for ovarian cancer. Finally, I want to mention the trial that we have open here. Oregovimab is an antibody against CA125. And this is an adjuvant study in patients with advanced stage 3 and 4 ovarian cancer who have optimal debulking, receive chemotherapy with oregovimab. So we're going to see the progression-free survival, and either patients who have surgery up front or patients who have neoadjuvant chemotherapy are eligible. So we opened this study a few weeks ago, and we're really excited to accrue patients and see if this drug is another one, hopefully approved and, maybe added in a discussion of this kind of few years down the road. So let's go back to our case. So we had a patient who had advanced ovarian cancer, no family history of cancer. So how do you manage this patient? So in the 20th century, for this patient, the standard therapy would be surgery, followed by adjuvant chemotherapy with carboplatin paclitaxel, probably just a platinum-based doublet, 6 cycles, followed by surveillance. Most of these patients will recur. Whether they recur within 6 months, we call platinum resistant. If patients recur after 6 months, we call platinum sensitive. However, that was it in the 20th century. What about now? Well, the first question is, are the patients debulkable to R0, which means no residual disease? That, a gynecological oncology will make that decision. If they say yes, yep, they go to surgery. If they say no, neoadjuvant chemotherapy. Oh, how about HIPEC at the time of surgery? If a patient is debulked to R0, definitely that is an option, like I mentioned. How about after surgery? If the patient has no residual disease or residual disease of less than 1 centimeter, we can do IV chemotherapy, or we can plan for intraperitoneal chemotherapy, which does have data for progression-free survival and overall survival. If the patient has residual disease more than 1 centimeter, what about bevacizumab? Like I mentioned, that has data too in high-risk patients and patients who had suboptimal debulking. Bevacizumab is given with chemotherapy and maintenance. And then how about surveillance? Well, now we have 3 options for maintenance after chemotherapy. Bevacizumab maintenance, like I mentioned, for patients who have received bevacizumab with the chemotherapy. PARP inhibitor maintenance, niraparib, like I mentioned, is approved for all patients. And PARP inhibitor and bevacizumab for patients who are HRD positive. So, and how decide which maintenance to use? Well, that's where germline testing and molecular testing and HRD testing comes in. So I hope these slides helps understand why I chose the title for this talk, How the Plot Thickens. And I'm open to questions now. I'm not sure I can see. Yeah.
Dr. Paplomata, that was fantastic. Let me just go. Okay, and I think there's going to be several questions, and I'm glad to know your first name is Elsa. And I just wanted to let you know, I was looking at the panelists, and it's real, the participants, a wide range of people from outside the department. So welcome some of the surgeons, some of the researchers. So really many people interested in this. And Carrie, I might have to hand off to you if I can't pronounce the names of these questions. So go ahead and let's take a look at those questions.
Okay. I'm going to ask a question if that's okay while I'm waiting to see some come into the Q&A.
Yep.
Is that all right, Elsa? So,
yep.
So one of the questions that I know has come up with the significantly improving outcomes in these patients is, what do you do about other cancer screening? And in particular for BRCA mutation carriers and their risk for breast cancer, but we could think about colorectal cancer or other screening. So what do you think is the right approach for people who still have this type of cancer?
Well, it's a very good question. And I think that's where the high risk clinic comes in. Dr. Barolette and you, do have a high-risk clinic in the breast center, and we're very happy to use that clinic from time to time. We like to see patients not as identified by their cancers, but as a whole individual, as a person. We have to take care of the patients as a whole person, and we have to know that someone who has a BRCA mutation is at risk for breast cancer and colorectal cancer, pancreatic cancer, like you mentioned. What I usually do is I refer these patients to the high-risk clinic. Patients who have a BRCA mutation could be eligible for MRI screening for breast or possible bilateral mastectomy. Patients also may be eligible for pancreatic cancer screening with a CT or an MRI of the abdomen. We do refer those patients for screening for other cancers, if I answer that question.
Mm-hmm. Elsa, can I ask you a question from a primary care perspective? So the high-risk clinic you're talking about is multidisciplinary. Can you talk a little bit about, what kind of providers are in that clinic and the services offered?
Well, like I mentioned, Dr. Barolette is a gynecological oncologist, and she's one of the providers. And Carrie, Dr. Wyszynski also is in this clinic as well. So essentially, again, it's a consultation, and recommendations are made for what screening is required. Dr. Uboha, I know, is someone I reach out to. She's one of our GI oncologists. So for a BRCA2 patient who may have pancreatic history of pancreatic family history of pancreatic cancer, I often reach out to Dr. Uboha because she manages these high risk patients, and like I mentioned, she's a GI oncologist.
Thank you. So either everyone has understands everything perfectly with this. So is there any other, Clint, do you see some questions in the chat?
Let me see. I opened the chat here. Let me see. I have here. Oh,
Mary had a couple comments.
Thank you, Mary, for your comment. I like that. Yep. And like I mentioned, many times patients, we see that in the chemo clinic. Patients ask, should I have a colonoscopy? And yes, possibly not when they received active chemotherapy. We don't want to have any bleeding complications, but at the end of 6 cycles of chemotherapy, then I definitely tell patients, hey, you have to look out for yourself. See your primary, get your lipids checked when your primary recommended, get your even patients who are BRCA negative. I always encourage patients after they're done with their chemotherapy, hey, see your primary, get your lipids checked, get your colonoscopy if you're over 45 or 50. Get your mammograms, of course. Get your DEXA, your bone density. That's another big issue. I do see a lot of women patients who receive chemotherapy, who are postmenopausal, can have low bone density, low vitamin D. So definitely, I refer those patients for screening for other cancers. Someone who has metastatic disease, for example, and is on active chemotherapy, that might be another issue where, of course, you have the toxicities and they're suffering with toxicities of their cancer therapy. But again, this talk is about the upfront management. These patients, hopefully most of them, many of them are going to be cured, and we don't want to neglect other parts of their health while we complete their treatment for ovarian cancer.
Also, I think there's one other question that came in, which is talking about all these newer therapies and whether there's any indication for any of these therapies for patients who do have their cancer diagnosed with lower stage.
Well, that's a very, very good question. Actually, some of these, that's a very good question. Stage 1 disease limited to the ovary, 1 or 2 ovaries. Stage 2 is limited in the pelvis. Many actually not, if we look at the NCCN guidelines, they do mention that, for example, intraperitoneal chemotherapy, they do mention, even though the data is mainly in stage 3 disease, they mention that this can be offered in patients with stage 2 disease if they have optimal debulking. Patients for the maintenance, for example, I do note that the PARP inhibitor maintenance has been done in stage 3 and 4. However, if we look at the National Cancer Guidelines, they do mention patients with stage 2 disease can benefit as well. So I think we can extrapolate this data to include stage 2 patients. For stage 1, it might be kind of hard to add a lot of these therapies because, again, these are more lower risk patients, and this is where you kind of individualize and you kind of have to balance the risk and the benefits. So these treatments I mentioned can potentially expand to stage 2. Yes, that's a very good question. Thank you for asking that, actually.
Well, Dr. Paplomata, I think that she has clinic at 9 o'clock, so I think you're free to do that. And I just want to say thank you, and I really look forward to meeting you in person, hopefully in the next few months. And so thank you very much. And thank everyone for joining us.
Thank
And
you
we
very
are
much. It's
done.
an honor.
Thanks.
Oh, I apologize. Thank you. It's an honor.